Good afternoon and welcome. Thank you for joining today's webinar, The Effects of Expiring Pandemic Relief Measures on Coverage and Affordability, a Future Outlook. I'm Sarah Dash, President and CEO of the Alliance for Health Policy. For those of you who are not familiar with the Alliance, welcome. We are a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. You can join today's conversation on Twitter using the hashtag AllHealthLive and join our community at All Health Policy as well as on Facebook and LinkedIn. Today's panel is going to have a Q&A section at the end of the hour, actually hour and a half. We would like you all to be active participants, so please get your questions ready. There's a dashboard on the right side of your web browser with a speech bubble icon. Go ahead and send your questions in through that icon at any time during the webinar, and we will get to as many as possible. And as well as if you have any technical issues, you can go ahead and chat about those. Today's briefing is brought to you in partnership with the Commonwealth Fund, and I want to thank the Commonwealth Fund for making this possible. Also want to thank the Alliance team members who contributed to the development of this webinar, Chris Holt, OK Enya, and Devin Lara in particular for making this possible, as well as Ray Contractor. And so now I'd like to introduce the panelists who will be joining us for this in-depth conversation. First, we will hear from Dr. Sarah Collins. She's Vice President for Healthcare Coverage and Access at the Commonwealth Fund. She's an economist and joined them in 2002 and has led the fund's national program on health insurance since 2005. Katie Keats provides following the ACA Rapid Response Analysis for Health Affairs Forefront, and it is the director of the Health Policy and Law Initiative at the O'Neill Institute for National and Global Health Law at Georgetown University Law Center, where she also teaches a course on the Affordable Care Act. Katie also serves as an associate research professor at Georgetown University's Center on Health Insurance Reforms, and as an appointed consumer representative to the National Association of Insurance Commissioners. Welcome, Katie. We will hear from Kevin Patterson, who has served as Chief Executive Officer of Connect for Health Colorado since April of 2015. He previously served as Chief Administrative Officer and Interim Chief of Staff to Governor John Hickenlooper, has an extensive history of public service. From his time at Connect for Health Colorado, Kevin has been focused on improving the customer experience so they can focus on health insurance. Scott Brockman will be our next panelist. He's the Vice President of Marketplace Strategy at CareSource, and he has worked in the healthcare industry for over 20 years. While at CareSource, he held the role of Chief Actuary, building out their actuarial and risk adjustment capabilities to support members in their Medicaid, Marketplace, and Medicare lines of business. He's currently the leader of CareSource's Marketplace product, helping the organization manage through environmental changes and the Affordable Care Act to support the members that they serve. And last but most certainly not least, we are thrilled that Elizabeth Rowe will be joining us. Elizabeth is principal at Levitt Partners, where she develops and manages complex multi-sector alliances and advises and informs clients on the impact of federal and state healthcare issues and how to effectively engage with policymakers. Liz specializes in private health insurance, FDA, Food and Drug Administration related regulated products, fiscal policy, digital health, and biodefense. She is also a subject matter expert in Senate rules and procedure, federal authorizing, budget, appropriations, and rulemaking processes, and she will have a lot of insight to share with us today. So with that, let me now turn to Sarah Collins, and Sarah, take it away. Thanks.
Thank you, Sarah, and thank you to the Alliance and the panelists for today's briefing. Both Medicaid and Marketplace enrollment have climbed over the course of the pandemic, and the number of people uninsured in the US has trended down. I'm going to spend just a few minutes explaining what's driving these coverage changes and how Congress can protect them. Next slide, please. CMS reported this month that 17 million more adults and children were enrolled in Medicaid and the Children's Health Insurance Program in March 2022 than in February 2020, bringing the total number of people enrolled to nearly 88 million people. Why has enrollment surged like this? The Families First Coronavirus Response Act of 2020, commonly referred to as FCRA, required states to keep people continuously enrolled in Medicaid in exchange for enhanced federal matching funds through the end of the COVID-19 public health emergency. The Congressional Budget Office estimates that this provision has increased Medicaid enrollment by about 13 million people. Why did this make such a big difference in Medicaid enrollment? Simply put, prior to FCRA, existing state and federal policy made it hard for eligible people to stay enrolled in Medicaid. Under federal law, states must verify that Medicaid enrollees remain eligible for coverage at least once a year, but many states check eligibility more frequently. Some states allow as few as 10 days for enrollees to submit documents to prove eligibility. Even small income bumps, like from seasonal work, can lead to disenrollment, even though income might drop again in a few months. Consequently, the average length of enrollment in Medicaid is less than 10 months. Exhibit 2. Marketplace enrollment has also climbed to more than 14 million people, as you can see in the orange line on this slide, on this chart. Have to go to the next slide, please. The primary reason is that the American Rescue Plan Act, or ARPA, lowered premiums for marketplace plans by enlarging the subsidies that people get for them. This led to an average per person monthly savings of about $67. CBO estimates that the ARPA enhanced subsidies increased 2022 marketplace enrollment by 2.3 million people. If you look at the blue line on the exhibit, you can see the combination of these two policies, continuous enrollment and the subsidies, has helped to drive the number of people uninsured lower. The bad news is that these coverage and premium protections will expire within a few months. First, the ARPA subsidies will expire at the end of 2022. Second, the continuous enrollment requirement in Medicaid will end when the public health emergency ends sometime next year. This will trigger a massive eligibility redetermination effort by states for all Medicaid enrollees. People will lose Medicaid coverage both because of actual eligibility changes and because of anticipated errors and documentation barriers. The end of these two pandemic policies have led CBO to forecast that over the next 10 years, marketplace enrollment will fall by 1.4 million people in 2023, with further declines after that. Medicaid enrollment will decline by 12 million by 2025. Consequently, the number of uninsured people under age 65 will jump from a low of 25 million people in 2022 to 29 people by 2025. Next slide, please. And that's not all. According to the Urban Institute, the loss of the ARPA subsidies and a less healthy risk pool as people leave the marketplaces will contribute to annual premium increases for people who are still enrolled, amounting to about $457 for individuals earning less than 150% of poverty, which is about $19,000 for an individual, $1,000 for people earning between 150% and 400% of poverty, and $2,000 for people earning more than 400% of poverty, which is about $51,000. It's important to note that the increases for the lowest income individuals could make it less likely that people who lose Medicaid eligibility at the end of the public health emergency will enroll in marketplace plans. They will just be too expensive. Next slide, please. People with higher incomes are also hard hit. Cynthia Cox estimates that in West Virginia or Wyoming, a 64-year-old with income just over the subsidy eligibility threshold in 2022, about $51,000, would see premiums shoot up from 8.5% of their income to a whopping 41%. Next slide, please. So what can Congress do to prevent all this pain and coverage loss? First, they can extend the ARPA marketplace subsidy enhancements. Second, at the end of the public health emergency, Congress could require states to conduct Medicaid eligibility redeterminations gradually and phase down the enhanced Medicaid matching funds rather than eliminate them as soon as the public health emergency ends. Third, Congress could provide a federal fallback option for people eligible for Medicaid in the 12 states that have yet to expand their programs. This could reduce the number of uninsured Medicaid eligible people in those states by an estimated 3.2 million people. Fourth, Congress could apply the lessons from the pandemic and make it easier for adults to maintain Medicaid by giving states a continuous eligibility option without the need to apply for a waiver, similar to what's available for children in Medicaid and the Children's Health Insurance Program. States that have taken this option have lower uninsured rates among children. And finally, Congress could require states to provide 1 year of postpartum coverage in Medicaid. Thank you, and I'll turn this back over to Sarah.
Thank you, Sarah. You've given us a lot to think about here. So let me now turn over to Katie Keith. Katie, take it away.
Great, thanks, Sarah. Thanks for having this event and for having me. It's just a terrific panel and I'm thrilled to be here. So I'm going to build a lot on what Sarah Collins actually just talked about and drill down a little bit more on some of the marketplace numbers. So if you could advance maybe 2 slides, that'd be great. So Sarah mentioned this, we actually have record high marketplace enrollment. We're at 14.5 million people enrolled in marketplace coverage nationwide for 2022. The data that you have in front of you on the slide doesn't go all the way back, but this is actually more than 2 million people more than the previous peak for open enrollment, which was in 2016. So you sort of had this episode where, you know, on the Obama administration's way out, you'd seen marketplace enrollment grow and grow year over year. The Trump administration came into office and due to some of the policy changes, and I think their, you know, unwillingness or, you know, inability to use the marketplace to sort of leverage and view it as a tool, you can start to see during the Trump administration, enrollment declined, not by a ton, but year over year. The state-based marketplaces, we'll hear from Kevin in just a second, did not see those declines. They continued to sort of push ahead. And so the real difference was what happened to federal marketplace enrollment. So if you had told me, as someone who watches the marketplaces very carefully, that we would see the enrollment shoot up so significantly during really what was only the Biden administration's first year in office, I would have been very surprised. But yet here we are, record high marketplace enrollment. State-based marketplaces continuing to perform, but really seeing about more than 10.3 million people enrolled through healthcare.gov. As Sarah mentioned, this is really the result, I think, of these rescue plan subsidies that are about to expire at the end of the year, as well as broader Biden administration policies, things like a 6-month COVID-19 special enrollment period that was held throughout 2021, additional investments in marketing and outreach. But really, I think the affordability changes are what is driving that pretty significant increase over time. So if you go to the next slide, please. You know, that has been a 21% increase in enrollment from 2021 to 2022 alone. And similar to some of the graphics that Sarah was showing, you've seen significant savings for consumers. So 28% of consumers selected a plan for $10 a month or less, seeing huge premium savings. Those enhanced subsidies, by making it more affordable to buy other plans, have also helped reduce deductibles, pull down out-of-pocket costs by enabling people to enroll in even more generous coverage. And so even from that chart, you can really see the types of savings we're talking about. Huge savings for folks, certainly at the lower income levels, and then all the way up by eliminating what the Affordable Care Act had previously baked in, that subsidy cliff for folks at 400% of federal poverty level, which is about $51,000, as Sarah mentioned. So huge savings that are all at risk at the end of the year. Next slide, please. Sarah gave some great data on this. I think we are, without an extension by Congress, we are very much on the precipice of what could be huge, significant coverage losses and premium shock for millions and millions of consumers. So, you know, estimates from the Urban Institute, more than 3 million people could become uninsured. There could be some very quick impacts, right? Especially folks who are losing that subsidy support may just not enroll, and some will go back to being uninsured as they were before. More than 10 million people are going to pay more in premiums if this isn't extended. This is going to be especially hard hit for middle income families who did not have any premium support before the American Rescue Plan. And as Sarah mentioned, I would emphasize, I think the biggest impact is going to be on older middle income Americans in rural areas. And that's because that is the part of the country where premiums tend to be the highest. And so that is where I think some of this premium shock will be most felt if Congress does not extend the subsidies. And you know, the timing here really matters. I'm going to be very deferential to Kevin and Scott on this because they can talk about it from an operational standpoint. But we sort of can't afford to wait until the end of the year to actually extend these subsidies. It is true they are in place through December, through the very end of the year. Folks will continue their subsidy support, their premiums will stay the same, but there's so much work that goes into setting those premiums, getting them through the marketplace, approving rates, doing consumer outreach, that everything really has to be lined up by the third quarter, which is, right around now or coming up very, very quickly. And again, state-based marketplaces and insurers, some of the outreach groups are all working on this and very focused on this, but the timing really does matter. I'm deeply concerned that even if Congress does come to the table and extend these subsidies, that so much will have already been done in terms of consumer outreach and notifications that we'll still lose people who otherwise would still qualify, even if Congress comes back later and does actually extend the subsidy. So I think this is very much something to pay attention to, and I do worry about sort of higher premiums down the road, as Sarah mentioned. If you have some significant coverage losses, I think insurance companies are going to, assume adverse selection and set rates higher than what they should be. So that's another reason I think the timing really matters here. I think that's it for my initial remarks, but looking forward to hearing the comments from the other speakers. So I'll turn it back to Sarah. Thanks.
Thanks, Katie. And before I let you off the hook, I just want to point out a couple things, right? Because it sounds like both you and Sarah are talking about a couple of things here. One is like the direct impact of, just speaking of the ARPA subsidies for a second, there's a direct impact of like enhanced, subsidies. And then you both also pointed to some potential market impact. So you both mentioned, so for those of the folks in our audience that maybe we're wondering, both of you mentioned older adults particularly, and also the potential impact of adverse selection just on market. So I just kind of wanted to point out that it sounds like there's two possible effects that you're talking about in terms of what might contribute to changes in coverage and in marketplace dynamics. So I just, I wondered if you had anything to add to that, or if you could kind of point out that piece, and then we'll turn it to Kevin.
Yeah, I think that's exactly right. I think two things I would add, one to channel Sarah. I think the other thing you won't have is you have to think about the Medicaid dynamics that she was talking about. So at the end of the public health emergency, if you don't have these sort of enhanced subsidies that are quite generous for folks at the lowest income from the poverty level to 150% of poverty, folks coming off of Medicaid are maybe not going to have such a soft spot to land in if you don't have this too. So I think it's probably three things. It's premium shock for current enrollees who might drop coverage. It is broader impacts on the market where premiums would end up being higher than they should otherwise be if these subsidies are going to be extended. And then it's sort of the Medicaid implications and seeing huge coverage losses because folks rolling off of Medicaid maybe are not making their way or finding the coverage affordable in the marketplace. So I would add that dynamic. And I guess maybe one sort of more macro point before I turn it back is we're in this world where the Affordable Care Act between Medicaid expansion and the marketplaces is at peak success. Peak enrollment, it's more affordable than ever. Congress has come back and sort of built on it for the first time. And I just feel like we're standing at the edge of this cliff and going, oh my gosh, look at this wave that could crash over all of this. Even at a moment where, we're 12 years out from the law being in place, I find it very frustrating that maybe that's the reality that's about to happen. But this is the strongest the Affordable Care Act has ever been. And we're still sort of waiting and watching to see what's going to happen next. So a little bit, thanks for indulging my editorial there.
Great, thank you, Katie. And now we'll turn to Kevin, who is managing a lot of these dynamics in a very important state, the state of Colorado. So Kevin, thank you for joining us today, and I turn it to you.
Thanks, Sarah. It's a pleasure to be here. I appreciate you all having me here this morning, still morning in the Mountain Time Zone. My name again is Kevin Patterson. I'm CEO of Connect for Health, the state marketplace for Colorado. Let's go to the next, because the panelists have already gotten me thinking about what points I want to make sure we emphasize today. So this graphic here just kind of lays out the work that we've been doing with our partners at the Colorado Department of Healthcare Policy and Financing on how we're working through to make sure all of our consumer outreach is supported by a lot of the work that we do with our existing stakeholders or brokers, assisters, the regional accountability entities who are our Medicaid providers under the Medicaid contract, and trying to make sure that they are able to push out health first information, which is the name for Colorado's Medicaid program, and trying to help us coordinate between a lot of the messaging that we provide, what we can work through with issuers, what work we can do to make sure that our RAIs, regional accountability entities have that, and we're working with our Department of Division of Insurance, rather, on trying to make sure that we're really, really coordinated amongst all those different actors on what message gets to the consumer, when they're going to get it, and who's delivering that message. And so we're really just trying to say that it's important for us to look at our special enrollment periods and how we can strategically use those in ways to make sure that the messaging gets to the consumer at a time they understand when they need to act, what they need to do, and how to make the transition away from what they have been maybe used to under the Medicaid without a verification and moving over into private insurance, which is a very different shopping experience. But usually, if someone knows that they have a doc, a prescription, a particular therapy that they're using, they know which type of network they're looking for, that we can send them through our quick cost plan finder tool to make sure that they're able to have continuity of care and they don't have a break. And so we're really working hard to make sure that we do that work in a much more coordinated fashion with our customers. We're also making sure that they can shop and enroll before the end of the 60-day period, making sure that anybody that's at the 150% of poverty is able to also come in for special enrollment period. So we've really been able to get people to use special enrollment periods as a way to continue their coverage, making sure that they understand how to use their coverage, and really partnering with those that the assisters and certified application centers that are close to a clinical setting, so that folks actually not just are getting insurance, but they're actually using it and understanding what the benefit of having insurance really means. And so having that clinical side supporting what we're doing on the health insurance coverage side has been, I think, really successful, especially in a lot of our rural communities where there's not a lot of competition, but if we can get them in the right kind of care and make sure that they're shopping in a way that extends their benefits and gets them in the right type of plan, depending on if they're a high, medium, or low user of health insurance, then they can find the plan that actually prepares them and has a financial benefit for them as well. So let's get to the fun slide next. Okay, I thought we didn't want to have fun. All right, so without congressional action, we are looking at 76% of our marketplace coverage seeing their coverage reduced or eliminated with their financial help that they're receiving. We think you're going to see about 40% annual increase in spending and about a little over 25,000 Coloradans losing coverage. So I think, Katie said something I thought that was really important that I want to spend a second with. We are actually doing things when it's not open enrollment. We're pretty busy making changes to our platform. We have a number of state subsidies that we're supporting in Colorado with our 1332 waiver that we've received here recently. There's a good bit of work in what's supposed to be the quiet period, which of course has been under a pandemic for the last couple of years. But right now, here we are, our rates in Colorado, at least the preliminary rates were announced this week. We are working very hard with our Division of Insurance to see what those rates look like when they come back and begin to start talking to people about what do they do, how do they respond to what the changes may be, and then the question is, well, what are the changes going to be and when are they going to happen? Well, we can't wait forever to put something in the system. So we've got to build a system that shows what the plans cost, what the out-of-pocket max is going to be, so people can make informed decisions. And at some point, we have to send renewal notices out. And I understand that, healthcare.gov is not sending numbers in their renewal notices. And at first, I was quite shocked about that response. But then I'm like, well, you either are going to send a very large increase that people are going to get scared away from health insurance, or you're going to send current law, you'll send something low, and then they'll get a bill that they'll be like, wait, this is different than what I thought I was signing up for. And then you have the problem of, well, if Congress acts later, how do you actually get them to get the right information? So the timing of this is extremely important. And my largest concern right now is just the huge amount of consumer confusion we're all going to have to deal with in exchanges and Medicaid to try to figure out how to get people the right information when they're going to maybe get something wrong and then it changes drastically at the last minute. So, you know, we just get really concerned as exchanges about not just the fact that we've seen huge gains over the past couple of years. You know, we've had record enrollment 2 years in a row in Colorado. Now we have to worry about losing our standing with our customers that has taken quite a lot of effort and time to build up. So as we think about how important it is to dovetail this with what happens with the end of the public health emergency planning, you know, I think there's an opportunity to begin to think about how do we make sure we have better communication and coordination amongst all of our health policy world on how we communicate with employees and with consumers and how we use our employees to actually support other community-based organizations that are also seeing these folks dealing with other kinds of challenges they're having. So we're trying to make sure that we have a coordinated, a very strategic focus on how we're communicating and supporting other groups that are trying to have this kind of communication to make sure that we're able to leverage our effort and give that kind of messaging to folks that they can use if they see them and maybe the exchange is not there at that particular moment. So I think with that, I'm ready to cede the floor, and I'm happy to be around for questions.
Thank you, Kevin. And I see Scott is already on. So Scott, take it away from a plan perspective.
Yeah, thank you very much. Appreciate the Alliance for having me join the discussion today. I don't have slides to share, but I'll tell you everything that the panelists have already worked through and talked about. Really, from an actuarial perspective, that's where I'm going to go. Questions that we have in our industry. How do we manage? How do we make this easier for the member to understand? How do we rate this appropriately so that we can continue to be profitable to support the ACA going forward? So right now, we talked about timing is critical and key. Currently, all of the filed rates are there with the states being reviewed. Those will get shifted over to CMS, I think, in the next few weeks. So these challenges that I'm about to call out here, we've already had to make determinations around how do you rate? What does it mean? What kind of impact do we think it's going to have to the risk pool? So I would encourage the American Academy of Actuaries did release their annual drivers of health insurance premium change. So it's an issue brief. Look that up. There's a 2023 version. A couple things I'll pull out to note. So as we talked about, risk, identifying the risk pool, you're supposed to, all issuers are supposed to rate the risk pool based on a market average risk. But when you have things like the PHE ending, is it going to end? When is it going to end? Maybe not right now. That has an impact. Obviously, we had talked about on the Medicaid membership, but then what kind of Medicaid membership are going to come and then have the ACA as their availability in order to get coverage? States, when are they going, not only when, but how are they going to redetermine these members? Some have been have communicated this is what they're looking at, the Medicaid agencies. Others maybe haven't posted that as broadly, but there are different strategies about the length of time to do that. Who should be redetermined first? Are they going to use some AI logic to try to figure out who most likely could be redetermined and get that coverage? From an actuarial perspective, long COVID impacts, how does that apply? The family glitch fix that many of you have been heard about and we've been talking about. The subsidies we just talked about today going away. What if it's driving up the cost of insurance? What kind of member, what's the price sensitivity that would cause that member to continue to purchase coverage or may forego coverage because it's unaffordable? And then there were some other things around, in ACA, tightening up some of the rating mechanics around metal AV ranges and creating standard plans to try to reduce confusion, make it easier for the consumers. We're living in a world of high inflation, 30, 40 years highs now of inflations. What does that do from a impacting trend, and what are issuers putting into the rates for that? Future COVID strains, we're living through yet another variant. And then, costs that are no longer going to be covered by the federal government. So funding around, vaccines or testing, all question marks that we've had as we've tried to set up, what we think appropriate rates would be as we've designed the products and filed those for 23. So very complicated. I'll move into, so what can we do about it? And we've talked about, several things already, but, from an actuarial perspective, I keep going back to how do we stabilize the risk pool or make the risk pool more known? So obviously making policy decisions earlier in the year to align with the rate cycle is what everyone would appreciate. From a renewal letter process Kevin had just mentioned, that is critical. What are we going to tell our members when we try to have them renew? Are we going to give them an estimate of what they had, what their current coverage is or subsidy levels are? That doesn't really make it satisfying, because that potentially will change. But we're right in the middle of developing all of those and getting them into production. Something has to be out there. State waivers considerations, again, Kevin mentioned that. Some of the tools that have been used, like a reinsurance program, it's a one-time tool. It might reduce overall premiums for for the given year that it's implemented, but long-term trend will continue on and persist. Disclosing Medicaid agencies as much as they can disclose and communicate the redetermination methodologies within the states. That's extremely helpful to issuers, so that we can figure out how do we work more hand in hand with them in order to help members as they move and stay covered between Medicaid coverage to our ACA coverage. Care Sources Managed Care Plan, and so there are some plans that kind of live in both of these worlds, Medicaid and ACA. So can we make some creative ways of sharing and communication, reach outs with our call centers in order to help support members through this coverage journey. Extending the subsidy, obviously, before the end of the year, the ARPA subsidies would be extremely helpful, again, to help with our members understanding, what is coverage going to be like or look like in the future. The other thing that we've been looking at, and it's very difficult to do from a risk standpoint, is if you do, issuers, if they do have both Medicaid and ACA coverage, what kind of members do we think are most likely to redetermine? What kind of coverage acuity load do they have? And can we estimate what their costs would be under our ACA coverage versus Medicaid? Extremely difficult. No one expected this to last as long as it has. And so even knowing which members might redetermine within an issuer side is very difficult at this point. You can't just say, those who look like they should have redetermined back in 2020, April of 2020 or May are on the list. It's not as simple anymore based on the length of time. So with that, I will turn it back to Sarah for our next panelist.
Thank you so much, Scott. And I will say you've just spent the last 10 minutes or so just outlining a dizzying array of questions and uncertainties. And so look forward to the discussion in terms of how we link sort of these policy decisions to the operational questions and challenges that you're facing as a plan, and then to, of course, what ultimately the consumer journey ends up being. So with that, Liz, really looking forward to hearing from you. And because we're not talking about any of this stuff in a vacuum, there's very live conversations happening in Washington right now as we speak and across the states. With enormous implications, and there certainly isn't agreement from all quarters on sort of how to proceed. So
no, as you know, we were talking before we started here that this is a great timing for this conversation, not only as folks have already talked about as far as, you know, where we are in kind of rate filing, but also where we are kind of in the congressional calendar, and really at this point where, you know, policymakers have to start making, you know, some decisions. So maybe we'll talk through a couple of the factors that they're thinking about. We can move to the next slide. So first, obviously, since, you know, so many folks had talked about, and we can even go to the next slide also, thank you. Perfect, and I think if you click again, the whole thing will pop up. You know, clearly based on what we've heard from all of our, you know, previous panelists, the reauthorization or extension of the APTC subsidies from the ARPA legislation is kind of a central question to what is the market going to look like. And, you know, for Congress, they kind of have two paths forward. One is a process called budget reconciliation. The other is what we call regular order, which would require some type of bipartisan deal. On the budget reconciliation side, you know, as folks may remember, last year there was a lot of focus on President Biden's Build Back Better agenda, which included a number of policies on, you know, taxes, climate change, healthcare, and the expansion of the ACA subsidies was a central part of that package. In the fall, the House, I guess, had passed their package, and it just was not able to come up to some type of agreement in the Senate. So since then, there's been kind of conversations behind the scenes with Senate Democrats and the White House around, you know, what is a package that could actually pass the Senate and then get sent over to the House. And kind of key in those conversations has been Senator Manchin, who has raised concerns about, you know, some fiscal responsibility issues around debt and deficits, and then particularly inflation. So while it seems like there's been nothing happening in this, you know, space for months, behind closed doors, again, there's been a lot of conversations around, you know, what can you do in kind of three areas: healthcare, taxes, and climate change. And just over the last week or so, we've started to see some kind of public momentum around portions of the healthcare package. And, you know, the first piece of that is policy around prescription drug prices. We're not going to get into the details of that, but the Senate Finance Committee, you know, released new language that would save $287 billion over 10 years. They have a CBO score for it, and they're kind of starting to talk through the process. That's really an important piece of putting together a kind of a reconciliation package. Because number one, it's going to help them figure out kind of what they have the votes for in the drug pricing space, but also how much money or savings they have to play with. One of the things that I think congressional Democrats have been clear on is that they want to have whatever they do within this budget reconciliation package, they want it to be paid for. And so you kind of need to know what you're working with in order to figure out, you know, within budget reconciliation, there's so much numbers going on that you kind of have to make sure that at the end of the day, you know what you're able to do. Some of the policies around APTC expansion that are on the table include a short-term kind of reauthorization of probably 2 years, 3 years maybe. We've also seen policies for a permanent. There's also been some conversation about changes to the policy itself. You know, do you get rid of silver loading and put, you know, back in cost sharing reduction subsidies? You know, is that something that you could still get, you know, significant coverage for individuals and maybe lessen the score a little bit? Are there things that you could do on further means testing, or, you know, the affordability threshold within employer sponsored coverage? So, you know, particularly as the experts on this call know, you know, better than most, there's so many different dials that could be turned that folks are talking about. And then the third piece of the package that's kind of emerged is Medicare solvency. And well, obviously we're not going to focus on that in detail. I think the reason I'm mentioning it is because of these concerns around inflation and deficits and debt, there's been this question mark of like, okay, well, what can you do about it in this type of legislation? Like, what's the it that you can actually do? And it seems like within the healthcare context, the it is being able to show that you're making Medicare more solvent for 1, 2, 3 years. So I guess from my perspective, you're starting to see the contours of what a health reconciliation package could look like. So you've got the drug pricing pieces. Last night, I think Senator Manchin, this was in a lot of the press, had made a comment, I guess, that, where he's at right now is that he would support 2 years of expansion of the APTC subsidies. In the past, he hadn't been, super clear publicly on where he was going to fall on that, but right now, at least that's what kind of press reports are telling us, is that he's signaled that that's kind of his line in the sand. And then the third piece of, really important being kind of the Medicare piece. A couple of things just to think about within this budget reconciliation kind of context, and for the members having this discussion. Obviously inflation, we just talked about that. One of the things that's really interesting, as some of the other panelists talked about, is you have to take into consideration, what's the cost of expanding the subsidies, but there's also a cost of not expanding them, right? And so CBO, the Congressional Budget Office, put out updated estimates of just overall healthcare spending on subsidies about 2 weeks ago. And one of the things that the Congressional Budget Office notes is that they think that there were more kind of younger and healthier individuals that came into the individual market because of the enhanced subsidies than they had originally projected. And they're kind of viewing the world as, yes, in 2023, if there aren't the enhanced subsidies, you'll see some premium spike and you'll see some loss, but you might see some of those young kind of people still stay on. But really in 2024, you could see a really significant premium spike. And one of the things that oftentimes we forget is that the spending, federal spending on ACA subsidies, is tied to premiums. So as premiums go up, you're actually spending more. And so again, they're balances. You have to kind of look at it, but know as a policymaker, that if you choose not to expand the subsidies, you at least need to know what the budgetary kind of constructs look like on that side. The other thing I would say, in addition to budgetary math, is political math, and unfortunately, that's a very real consideration. I think one of the things that I would be thinking about if I was advising a policymaker is, if you're only able to do a short-term expansion, what does that look like, and kind of what are the years? If you do 2 years, you're bumping it right up against a presidential election, and is that something that is, wise for folks? I'm not so sure. The other thing that I think the context that folks need to understand is, as we just talked about, is deadlines. There are very real deadlines and ramifications of not reauthorizing the subsidies, both for states trying to do rate filings, for consumers. The other thing is that the budget reconciliation, this ability to pass a bill with only 51 votes in the Senate, that goes away October 1st. So for many in Congress and in the administration, they're looking at October 1st as kind of the deadline for when they need to get this done. Whereas I think there's some pressure to say, no, actually, really, August 1st has to be the deadline. And so you're seeing increasing pressure to try to get something on the Senate floor in the next couple of weeks. And I'll talk about the process on that a little bit in a second. I do just want to kind of briefly touch on kind of the bipartisan path. And this is something that a lot of folks, I get asked this all the time. What exactly, Republicans generally in Congress haven't been supportive of the ACA expansion, but couldn't they support like a year or two more if it's combined with something that Republicans want? And my general view is to never say never. But this is one where I feel like congressional Republicans have been so strong in their concerns about the APTC spending in the past. Obviously, we saw kind of their concern around cost sharing reduction subsidies. I have a hard time seeing a bipartisan path of some type of deal, particularly given what if you're a House Republican or even a Senate Republican and you think there's a chance that you're taking Congress back next year, just doesn't seem like it's aligned to see something bipartisan. The other thing is vehicle. There's just not a lot of bipartisan bills moving. And so really the main legislative vehicle to get this done would be a continuing resolution in September. That's going to be fraught with a lot of other issues. So again, it seems really unlikely to me that you'd be able to get, a bipartisan deal and move it on a CR. It seems to me it would put the continuing resolution at risk if you tried to do that. Last two things, a Hyde Amendment. I think the Hyde Amendment is an amendment that goes on appropriations bills. It's also in some laws that restricts the use of federal funds for abortion. The ACA also has its own restrictions on the use of subsidies for abortion, but they're slightly different. And in the past, congressional Republicans have raised concerns about the protections that are under the ACA and their preference for the Hyde Amendment. In the past, when you've seen focus on, trying to reauthorize cost sharing reduction subsidies, that became the big hang up. And that's kind of where I get to 2017 lessons learned. In 2017, the individual market was, facing some stabilization issues, and there were attempts to try to come up with a bipartisan compromise to address and to stabilize the market. And the backdrop of that was, this was before silver loading. So it was the possibility of bare counties, significant increases, and repeal and replace had died. So really the only thing you could do was bipartisan, and it still blew up. And part of that really was because of some of the Hyde Amendment issues. Parts of it also was just around kind of spending. But just wanted to say, I think not to be too overly negative about it, but I think the way I view this is to get this done, it's really budget reconciliation, or nothing at this point. So if we go to the next slide, and we'll do this really quickly, this is just a reminder of folks, kind of what I just said of process-wise, if the Senate was to be able to cut a deal on reconciliation, how would this happen? And so, and we can, if people have questions, we can do this in much more detail, but essentially, what we would see happening if they have a deal is that the Senate would take up the House reconciliation bill that already passed, and then they would put in their own kind of substitute amendment, hopefully pass that, and send that back to the House. It sounds kind of easy, but it's really not. And there's a number of different rules around reconciliation and ways that policies have to comply. So there's a lot of kind of back and forth processes that have to go into that. But happy to talk about that in further detail if needed. And then finally, last but not least, kind of what can the administration be doing while Congress is sorting itself out? And we can go to this next slide. That would be great. And I think as folks talked about, extending the public health emergency, we're expecting, if it hasn't happened already, an announcement on that today. Rate filing flexibility. This is something that we've seen, states ask for, is the ability to kind of adjust and refile rates as needed. We've talked about this. A lot of folks have talked about the additional guidance on Medicaid redeterminations. Also kind of increase consumer support and communications. So continuing to have those increased focus on talking to consumers and making sure that they understand kind of how to navigate this. And then also, if we do see a situation where it's later in the year and the subsidies are somehow being reauthorized, which technically could happen if they have like another budget resolution, but it's tough. You could see some type of, special enrollment period or something else next year to try to make up for the fact that you had a slightly confusing open enrollment period. So happy to leave it there and answer any questions. I wish I had a better kind of crystal ball answer, but at least these are some of the things that we think that policymakers are thinking about now. Thanks.
Thank you so much, Liz. And while I invite the rest of our panelists to come on for Q&A, you've really outlined, while the other panelists and Kevin and Scott in particular outlined a lot of the real important operational questions that states and plans are facing in order to try to get coverage to their members. You outlined a lot of political and policy uncertainties and in a very short time frame. August 1st is in 2 weeks, right? If that's a true deadline. Yep. But I can't help thinking about the time I was in 6th grade and waited till the last minute to finish my science project. And it feels like that's how a lot of policy making gets done, kind of for better or for worse. And because of some of the challenges, I'm going to want to talk about the longer term implications here on this panel for sort of bipartisanship and kind of longer term, more sustainable planning as obviously people in American households have to do household planning too, and they're doing their household budgets and wondering like what that's going to look like, and they're obviously juggling a lot of other considerations right now as well in the current economic environment. So, but just to take it back to like the next 2 weeks or 2 months, you know, I mean, what, from your perspective, do you think people ought to be like, if you're sitting there at your kitchen table and watching the news, like, what do you think are signals coming from Washington that people should be paying attention to? Or is this all just so inside the beltway that like it's dizzying and it's impossible to keep track of?
So yeah, so I would say it's almost, I would have two things. On one, I would say it is kind of inside the beltway. The negotiation at this point really seems to be that Senator Manchin has a lot of power, and because without him, they've shown they can't pass anything. And he's kind of been focused on a number of different policies, and now is the time where it's kind of, they're seeing if there's a there there. And last night, I think he made some announcements around, you know, didn't feel like he could go there on some of the climate change, couldn't go there on some of the taxes. So it's really emerging that it could be that the only thing that might be able to move is kind of this small healthcare package. So if I'm, you know, a normal human out in America, I would say, please just try to enjoy your life and go to the beach. Don't get sucked in. If you are a stakeholder, if you are a healthcare stakeholder and you care about these issues, no matter what, I would really encourage you to try to share with your members of Congress and the committees of jurisdiction the impact in your districts, and at a very detailed level. And again, goes either way, right? This is no matter where you are on the issue. You know, we saw some of the impacts of kind of overall what happens if the subsidies aren't reauthorized. To a member of Congress, that's impactful, like when you're on committee or in your leadership and you're thinking of policy big picture. But honestly, what they care about is what's happening in their county and what's happening in their state. And so the more you can personalize the impact, the better. The other thing I would say is, you know, I worked for budget committee and then health committee, and I can tell you with all honesty, like there's not enough of an understanding of like the rate filing process and what some of those deadlines are. So in DC particularly, you hit it exactly, Sarah. It's like, not only are they doing their homework at the last minute, it's like their dog ate their homework. They, you know, then they lost their notebook, and then they were sick for 3 days, and then maybe they like pass in like a third of what they were asked to do, like a week late, and then they're just like, all right, I did it. Like that's kind of where we're at, sadly. And so I just think the more you can be educating people about when timelines are real and that they're going to have real impact and what that means, you know, that's what I would be saying. So, you know, the average American, I would just say, go to the beach. But healthcare stakeholders, I will say, engage, and really try, again, focus on real world impacts and really focus on kind of local as much as possible. And I think that's, particularly in the ACA context, as you said, Sarah, like it's so political. Of all the issues I worked on, there's no other issue like this where it's almost like it's so impossible to have a detailed conversation because everyone's at it's amazing, it's awful still. And so again, the more you can break away from that and get into like brass tacks, I think you have a much better chance with members.
And Sarah, I think one thing that is like top of mind for families right now, maybe not everybody, but like in the wake of Dobbs, I guess I would just connect some of this discussion to access to, I don't know, contraceptives and maternity care and abortion where it's covered. And so I think I don't know that you can like fully always divorce some of the conversations we're having about abortion from coverage. And I would maybe emphasize that too, that to the extent that there's a lot of uncertainty out there and folks are not feeling stable in their access to healthcare, having a world where we're not filling the Medicaid coverage gap in the state, you know, that has sort of maybe fallen off given the news last night that those 12 states will be left behind. Those are some of the states with these restrictions without, you know, a lot of coverage, if any, for adult, like just real challenges there and some of the worst maternal health outcomes. I think contraceptive access through the marketplace and all these other places, right? If you're going to have a bunch more people uninsured at a time when you don't have access to abortion, there's a real maybe crisis there too. And so if we were going to tie this a little bit to something that is probably even more top of mind than, marketplace deadlines, which I tend to agree is not there, I think there's a strong link between what's happening with reproductive health care and the need to make sure folks have the coverage that they need. So we just add that in.
Yeah, thanks for pointing that out. I mean, it's certainly for anyone who's sitting there with, any kind of condition, diabetes, heart condition, what have you, right? And like those are the people who are waking up every day kind of wondering what is going to happen to their coverage, more so than probably like somebody that's healthy enough to go to the beach, right? That's kind of the point you and Sarah made about risk selection, right? And I think Scott also kind of made this point about if you're dealing with a health condition, you're more perhaps likely to be tuned in to some of this stuff, and like maybe you're more willing to spend more money even if your premium goes up to stay in the marketplace than someone who's otherwise healthy. Is that a fair thing to say, like for Scott, our actuary friend, and maybe Kevin, as you're looking at like the rate filings, like how do you translate some of these numbers of like these really big broad numbers about what coverage loss might kind of look like into like who's really going to be affected? And we all know coverage, it's not like we all wake up and we want coverage just for the sake of having coverage. It's hopefully to have access to care and then to health outcomes. So like how do you think about that in terms of your data and your patient member populations?
Yeah, so I mean, it's very much what Liz had said. From a strictly West Virginia, it's probably the highest premium in the nation, or second highest. And so those subsidies, the amount of members that are subsidized, at least $1 is higher than anywhere else. So it's critical for them. I mean, they cannot afford the cost of rural healthcare there. I won't blame it necessarily on even the networks. It's the cost to try to provide coverage in where they live. And so back to exactly what Kevin had shown. We are advocating, especially in West Virginia, with the Mansion link there, that this does have an impact on the people that you serve. And the issue that we have, we need flexibility. Issuers have to have the ability and have some guidelines to live within when you set a rate. But it's very challenging. If everyone is making the same assumption, then like Liz said, the subsidy levels kind of all move together, and maybe we're covered from a sustainability side. But what if somebody puts in a market acuity adjustment? Happened when the individual mandate went away, of a 5%. I mean, I could be very competitive at a very unaffordable cost for the plan. So it's very difficult. You don't know what your competitors are doing, and trying to set something that's appropriate for the member, but then also allows us to sustain and be an option on these exchanges for the long term.
Yeah, thanks, Scott. Now, obviously, I won't put you on the spot in terms of CareSource in particular, but and I'm wondering if Kevin can chime in here too, but like to some extent, I mean, during the CSR debate, like we heard over and over that uncertainty creates higher premiums. Like you have to bake uncertainty into your premium. So, I mean, Kevin, maybe I'll turn to you. Do you think, from your perspective of like overseeing a number of plan offerings, is that something that you think is going to happen? And like, I think it was Elizabeth, I think you were the one that made the point about we might see more of a premium spike in 24. Is that the connection there to the timing, that like rates are already almost baked for next year or soon to be baked, and so we might see more impacts in a couple of years? Like, how does that work from your perspective?
So from where I see it, when Scott and his industry are nervous, we pay more because he's talking about risk. So nothing pejorative about what you guys do, Scott. I'm just saying I don't like to make y'all nervous because
Right.
that's what happens. I mean, and I think that if there were one thing, I mean, in years past, it has been, okay, individual mandate was 1 year, CSR was a different year. Now we've got multiple big things happening at the same time. And is if they're like in different planes of existence, but they're all going to impact it, but it's an assumption on an assumption on an assumption. And I think that's where there's a little nervousness, and rightfully so. And so it's hard to know exactly how that's going to play out. But I will say, when we think about how we're messaging, whatever the rates look like, messaging is important, but affordability is the key. And if you're explaining something that's affordable, it's a lot easier than explaining something that's not. And folks understand that, especially around kitchen table economics issues. If I could just say two quick things. One, I think, Sarah, your science project one was really a good analogy. But to me, it's like a science project, but everybody else gets the grade and not you. Because it's really the impact that they're having on other people that I think is a challenge for folks to understand. Well, why is this taking so long? Why can't they just figure this out? And folks, I think if they do pay closer attention, they're going to get more and more frustrated. So I totally agree with Elizabeth around that piece. And I think, in a lot of times what we've tried to do from the exchange perspective is talk about what the average looks like. And I don't think averages is the right conversation. I think it is about these real specific examples, like the one we were using in Colorado about what happens between the 30-year-old and the 55-year-old in rural Mesa County and the western slope of Colorado if the ARP isn't extended, because the age piece is a piece of this, and how much they're going to have to pay differently. And I think those are really impactful conversations for us to have, and we're happy to do that. We do that all the time, and it will be really important for us to kind of think about what rates look like in Colorado and say, all right, now this is what it's going to look like for you, because last year we're like, oh, rates are coming down, but then it was like, well, but if you're on financial assistance, you might actually pay more just because of the way the math worked. And so I think it's really important for us to wait until a little more of the dust settles before we try to explain things, because then you're going to be trying to explain what you explained before that might not be exactly the same.
Mm-hmm. Yeah, Katie, you had something to jump in, and then I have another question focused on Medicaid.
Yeah, well, and I might add, just from maybe a national perspective, I think, Sarah, you referenced the cost sharing reduction, right? This was a policy in October of 2017. President Trump shut off those payments. I would, in many ways, the marketplaces are sort of a victim of their own success, right? There was an incredible amount of planning that had gone into that. Folks were able to like flip a switch, and by November 1st, consumers never knew the difference. It was not disruptive at all. But having worked at this, NAIC and the state level and watched what states were doing, I mean, regulators were incredibly prepared. They'd asked, a lot of them had directed their insurers to file 2 sets of rates. Everything was baked. We were really prepped for that. And I want to draw a comparison to where we are this year, because that is not what's happening. And I'm validated to see some nodding heads along. States are, haven't been as directive to say 2 rates, one with rescue plan subsidies extension, one without. I think a lot of insurers are probably, I would like to think, are doing that on their own, but we don't have the same sort of, it has not been nearly a uniform response to this. States are doing different things. I think insurers are already letting premiums creep up as a result, even if they're doing with an extension because of all this uncertainty. There's sort of, we haven't seen, I don't think we're going to be able to flip the switch in the same way. And the other thing I want to add on that, even if states are as prepared as possible, where they've done, have 2 sets of rate filings, if Congress does anything to change from the rescue plan subsidy structure, right? There's been talk of maybe you would cut it off at 400, or maybe you would, do extra subsidies at this. And like, if it looks like anything different, these marketplaces, it's going to be a delay in implementing that, which then delays people's care and adds to the confusion and everything else. And so again, victims of our own success, where marketplaces bend over backward, and insurers too bend over backwards to make this work. This year, I think, feels different. And we will be very lucky if there is no disruption, but it's only because we're sort of putting folks through the ringer. So I often hear the CSR comparison and want to maybe emphasize how it's a little bit different this year.
Yeah, maybe just to jump off of that. So during that, I worked for Senator Lamar Alexander, who was the lead Republican trying to negotiate that bipartisan deal, and had here, I mean, so the difference congressionally, right, was that, like, I think it was like repeal and replace died at some point in July. And I've told this story before, but literally 5 minutes after John McCain, stuck his thumb down, Lamar Alexander starts walking behind on the Senate floor and goes over to the Democratic side bench in the middle of reconciliation at 2 o'clock in the morning and starts talking to Patty Murray. And we're all going, oh gosh, we're just exhausted. And we ended up spending 2 hours in a Senate hideaway with the Murray and Alexander staff that night / that morning, figuring out what we were going to do over August, because we knew what was going to happen, and silver loading wasn't a thing then. So in that context, you had August that was full on staff work, an entire month of hearings in September, drafting, legislation, trying to get it ready to move. Silver loading ended up happening. And so I think it actually ended up, partly because of silver loading, the urgency on the legislation kind of went away. But again, I agree with you completely, because even then you had a lot of congressional focus on figuring out what's plan A, plan B, plan C, and that's not the conversation you're seeing now.
I just want to point out what a remarkable story that is. I mean, like, that's remarkable on so many levels, and it's going to take me a minute to absorb that. But that, like, in moments after what had been a really partisan conversation that your boss then had reached across the aisle, that those conversations went on until 4 o'clock whatever time in the morning. So thank you for your public service, and to all of our congressional staffers who put in unbelievable hours behind the scenes, and then that you put in a ton of staff work. So anyway, I just had to pause and editorialize there that this stuff, everything we're talking about does not just like magically happen. So thank you. I want to move to a question from the audience, and I again want to remind our audience that we have about 20 minutes left for questions. And there was a question here about Medicaid redetermination, so I want to make sure we get to that, because a couple of you, Kevin, you sort of drew a flow chart of the consumer, the person's journey sort of through that. The question is around regarding Medicaid redeterminations. Do you have a sense of the profile of the individuals that are likely to lose coverage? Are you looking at maternity related, kids? Are you looking at income related? You mentioned, we've talked about the age rating a couple of times. Do you have a sense of the likelihood of where those individuals are likely to end up? Like, who's most likely going to get to take up coverage on the marketplace side, and who are you worried might end up uninsured? Like, is there sort of a way to stratify your audience, excuse me, your membership from that perspective?
So I think this is going to be not your regular Medicaid redetermination population. I think this is going to be a very heterogeneous population, which means we have to think of the different profiles of why people are coming off. Some will be through the regular determination. Some will be that they either are eligible or have moved on to employer-sponsored care, but usually Medicaid kind of goes through that and figures that out as they're going. It could be folks that are just like, well, I kind of know I can get Medicaid, so I'll just sit here until they tell me I don't, then I'll go over to the exchange. So I think we're just kind of ready to catch whatever comes our way. And it's kind of what we're used to doing anyway, whether somebody's coming out as a small business owner, whether they're a business of one, whether they've been laid off, all those kinds of things are what we're used to doing as exchanges. I think what I'm telling my staff is be ready for different personas of that population, and I don't think it's going to be a one size fit all in what we do.
Yeah, and I had mentioned, having both the Medicaid in some of our markets, having both the Medicaid and the marketplace side of things. We've tried to profile. It's just been so long that this has been on that, for the most part, we're seeing it's more adults, the non-traditional Medicaid situation, but then also, did they expand or not? So that, is there a lot of folks that are going to lose coverage under that? In one of our states, we don't have that, and so the marketplace has already been sort of a place for a lot of those members to go. So it is very difficult and a challenge to look at.
And Sarah, I want to bring you in, Sarah Collins, to bring you to the conversation. You've been in here for a while, so you're an expert on surveys, on consumer surveys, and sort of looking across populations. How are you thinking about kind of what the tailored or disparate effects might look like for different people or different groups of people.
No, that's, I think that what we're probably going to see is this end of the public health emergency playing out very differently across states. Just like we see now across the states, pre-FCRA, states handled eligibility redeterminations very differently. Some states are very aggressive and some states are less aggressive. And so in some states are going to be very eager to get people to move off their Medicaid off their Medicaid programs. And so you're likely going to see big spikes in uninsured rates, or at least gaps in coverage in some of those states. And in states like Colorado, which are taking a much more measured approach to this, less coverage loss. I'd also like to put this in the context of inflation, and these are people with very limited incomes. And when you think about affordability, what's important to think about is how much people are going to have to pay as a share of their income. So people eligible for the marketplace plans are a pretty moderate income group of people, and then people in Medicaid are a pretty low income group of people. So if you're looking at shifting from Medicaid, where you're not paying much at all or nothing in premiums, and all of a sudden you may face, if ARPA subsidies aren't extended, any size premium is going to be a disincentive for you to enroll in marketplace coverage. So people in the lowest income brackets are always the most hurt during high inflation periods, and having seeing a spike in premium is really going to be the last straw for a lot of these families.
Thank you. We have about 15 minutes left, and so again, want to encourage folks to ask questions. Let me go again to sort of our bank of audience questions here. You know, there's a question of, I think one of you mentioned this kind of earlier, is there any talk of funding the CSRs to help pay for higher subsidies? So again, like it sounded like, you know, that was unlikely, but, you know, from a federal perspective, I mean, like, is there any tinkering with the CSRs at this point, or are we just going to let silver loading be what it is?
You know, I'll just say we've heard in passing that looking at silver loading was one of the levers that potentially Congress was looking at as if they were going to kind of adjust the subsidy. Obviously, that gets really challenging. I mean, there's just challenging in the perspective of there's so many ramifications from it, right? So if I was in my old, you know, Hill job and was trying to figure out, okay, if you're trying to expand the subsidies, but maybe you have to tailor it back, that to me is it's got a significant impact. So I don't know if I, you know, think it's highly likely, but I do think it's one of the levers within how the tax credit is structured, that if you're a policymaker, you could dial up or kind of dial down.
Thanks. All right, audience, come on, you got to keep those questions coming. But Kevin, it looks like you were about to say something. Yeah.
Yeah, no, I just wanted to jump on something Liz was saying. I think I've heard a few machinations about what it would be different, whether it's a cliff at 700, whether we do 2 years, all that other stuff. The longer we go and the changes that we make, the more concerned I think state exchanges will be, and I think healthcare.gov will fall in the same place about actually being able to do anything at any time, because you're kind of burning up, you're running out the clock, and we just don't. I mean, we'll do whatever we can to get everything there, but there is just a limit to how much risk we take on in giving people the right eligibility if this continues to delay. So I just want to make sure that was stated.
Mm-hmm.
There's also a practical element, which we didn't touch on, but I remember kind of drafting legislation, we get technical support from the Department of Treasury. And anytime we changed anything related to like the calculation of the subsidy, and we didn't give them like a year to kind of like figure it out, The TA was, explicit. And so that's the other thing that I think if they're going to actually try to change anything with the calculation, the technical assistance that they're going to get from the Department of Treasury about whether or not that can be implemented, within a couple months is highly unlikely. So to me, I think if you're dialing, you're going to dial with years rather than completely reopen this thing. That just would be my assessment.
I like technical assistance is a good euphemism for I'm gonna use that myself. I guess I had a question maybe for Scott and Kat. I mean, if they did, appropriate CSRs for next year, I think you'd have to completely redo rates. I assume, or I don't know. I don't know that. I haven't heard anyone modeling that or like doing a separate rate filing for that. Versus even if you were going to do that, pushing that out for 2024, which is sort of what you suggested, Liz. But that to me seems extremely disruptive at this point.
So that's kind of where I was thinking that we've already loaded our rates based on expected silver blend, and so if all of the benefit comes to the issuer, it's going to the wrong place. It needs to get to the member, which means the premiums would have to be adjusted.
So, okay, there's going to be so many more process questions in a second, but that does lead me to a little bit of a related question that came in from the audience, which was actually it's quite a significantly related question, right? Depending on how you dial the policy, which is just like, where is the money going to come from to pay to extend the subsidies? And I think Elizabeth, in one of your slides, you kind of showed, right, some potential savings or offsets from prescription drug spending, which again, like, I think while the topic of this conversation is the specific impact or not of the APTCs and the Medicaid redeterminations, like it's probably not lost on anybody that that's a pretty significant chunk of money that, is certainly has been reported as coming out of the pharmaceutical industry. So I'm just curious, like, is that gonna cover the cost if it were to go through? Like beyond that, I know there's some tax sort of questions at play, but can you kind of talk about where the money's coming from, but also maybe just remind us if possible, like, is there a score of how much it costs to sort of extend the subsidies? Or again, is it all just still so in flux because CBO can't score anything until some key decisions get made? Sorry, that was a lot of questions, but so let's start with like how much we think it costs and then where does the money come from?
Yeah, I was going to see if Katie and Sarah have what they are thinking as kind of their most recent thinking on what the subsidy expansion would cost.
So I'm just a recent estimate, about $22 billion a year to extend the subsidies. And if you do the math on the prescription drug over 10 years, you're obviously offsetting the subsidy cost. I mean, I would also just add to this. We get really caught up in how much things cost and pay for us. But if you think about the ARPA extensions and then only doing them for two more years. I mean, these were changes that really did need to be made to the marketplaces. I mean, the subsidies really were not adequate for people. The cost sharing reduction subsidies are actually not adequate for people. People face really high deductibles. So this was an important change, and we did it during the pandemic. But just because the pandemic is winding down doesn't mean we should get rid of these policies. The continuous enrollment requirement in Medicaid, that's a very important change that allowed people to stay on coverage. And just because the pandemic winds down doesn't mean we should abandon that ideal of keeping people enrolled in Medicaid. So both of these policies were very important changes in and of themselves, regardless of the pandemic, and the expenditure is actually relatively low to make going forward on the subsidies.
Thanks, Sarah, for that. So we heard the estimate of $22 billion per year, and with the possibility of you can switch the number of years and that kind of thing. And you also made the point that Sarah, this isn't necessarily, while this happened during the midst of a public health emergency, that there were you know, and I think, let's face it, like over the last 10 years, not much sort of substantive has happened in terms of improving or fixing, right, sort of the current health insurance coverage system, if you will. So I guess with that, let me see if anyone has any further comments on this, right? I mean, like the fiscal piece of this is still obviously a concern to a lot of people. Like, what are the odds of overcoming that?
So I was just going to say, for offsets, you know, I do think the current thinking is that the drug pricing piece, you know, it's 287 billion over 10. I think there's a small piece of that potentially, I'm saying potentially, small p potentially, if I had to argue. So we didn't talk about the bird rule because that's so far inside the beltway, you don't want to go there. But it's one of those reconciliation rules that kind of limit what you can do. So I'm going to say safely they have 250 to 280 billion over 10. And I think what we've heard about the Medicare solvency piece is that there's an interest in having a dedicated new source of revenue that would go directly into the trust fund. So I think that there's plenty of, you know, I think there's room on the table, certainly to look at a couple of years of the APTC expansion. I've kind of described this as, with reconciliation, they're puzzle pieces. And they're almost like puzzle pieces that kind of like move. And we're starting to see them move towards each other and them start to fit. So just the fact that like they made policy changes within the drug pricing language that got them a higher score, that also probably helped make it easier to get done through the bird rule. Okay, so then that slots in. Well, that got them enough to cover, you know, more subsidies. So then that's going to help slot that in. And then if there's something left on the table, or, you know, a smaller tax provision that can give you something directly to the trust fund, that slots that in, and then you have a healthcare package. What happens on tax and climate, I think, is outside my, you know, world. I just think the question is going to be, if you're congressional Democrats, I don't know what else you get. If it's not this, I don't know what the other option is, because I don't see a bipartisan path forward. And I think that that's going to be the real conversation for policymakers, is if not this, what? And I don't think there is another option.
Yeah.
Liz, could I ask? Sorry, I'm just asking questions.
Please. Yeah, we want to foster dialogue.
I'm choosing ray of sunshine as usual.
No. I mean, setting aside like in terms of what else could be on the list that you're slotting in, right? So I think coverage gap is out there. I'd love maybe your opinion on that. And then there's, I mean, at least in the House passed version of Build Back Better, there are all these other Medicaid policies that are super important, you know, like permanent or mandatory, like 12-month postpartum, continuous coverage for kids, some really important, again, in the moment that we find ourselves in, that would be historic changes in Medicaid. I don't know if do you have an opinion on those or any insight into where those are sitting? I do not, which is why I'm curious.
Yeah, so I think so I really think the inflation numbers have not that they need to be refocused. I think Senator Manchin's very clear that he is going to scrub every single provision of what they do for an impact on inflation. And for me, what that means, it in some ways it's overall spend, right? Because some of those individual policies don't have kind of a direct impact, you know, on inflation. So I think if you can make the case, I don't know, I think it's a tough negotiation, in the sense of, you know, how do you draw the line between kind of what's necessary in this time and what's not. Again, I'm trying to think about it not so much from a pessimistic perspective, but if I'm really thinking of it from like a purely budgetary perspective, and I almost am agnostic on the policy, which is kind of what you have to do for some of these, is just to kind of think about it. It helps you make your arguments too. I think that's the other thing too. Sometimes particularly when you're dealing with budget reconciliation, I try to tell people, like, I'm a lawyer by training. I like words. I like statutes. That's the puzzle I like to figure out. The fact that there's numbers involved, like, that is hard for me, even though I worked at the budget committee. And so, but when reconciliation happens, you have to flip your brain, and you have to think, for me, is how are all of the numbers moving? And then kind of the policy almost becomes a secondary piece to it, which is just, to me, not how one should legislate, but that's just when you're in budget reconciliation land. So I'd have to look at the numbers, and see kind of what they look like, and how you can argue, through that inflationary lens is going to be, I think, a really important way to look at things.
Okay, I think, when a number of us state exchanges were in DC in May, we were making this same argument, and it was pretty clear they were talking about drug pricing. And I think what Elizabeth is saying is the budget becomes the policy question, because you can't say yes or no until you know what the numbers allow you to do. And so what we had to kind of just do is like, okay, we have to wait our turn, because we know we're not the biggest number for what we're talking about for the subsidies. And they have to see if they can squeeze out enough somewhere else to make this even an option. So, I come from a place where the budget is where you start. So maybe I just see it a little differently. That's all.
Yeah, I guess I'm thinking if we're only talking about subsidies for 2 years, that's 44 billion. What else is that drug? So that maybe leaves a lot of room in plotting. So it's just curious. Yeah, like the state of play on Medicaid, I guess. But this is super helpful. I totally agree with both of you, and that was great insight. Thank you.
Thanks, Everett. So this has been a really great discussion, and we have just a few minutes left. I want to let everyone go on to their afternoon on time. But I think just kind of to this point, right? It's like inside the Beltway, and in a reconciliation process, like the budget becomes the policy. We're talking about things that are, dialable in sort of DC terminology. Do we extend it only for 2 years? Do we means test? I don't know. We don't have maybe too much time to get into the technical details, but I think there was some report that maybe Senator Manchin had indicated that like he'd be fine with the ARPA subsidies only up to like the 400% of poverty, right, which also then creates a cliff potentially, right? So at some point, again, in sort of our last few minutes, I just want to sort of take the focus from the policy sort of to the people, and sort of regardless of how this current short-term situation gets resolved, are we just, and I get that this is a little bit more of like looking into the crystal ball, but this whole entire conversation, I mean, the number of times we've talked about timing, uncertainty, like, real pocketbook consequences for people. I mean, what does it take to get to a conversation where it's not these like short-term sort of lurching from one thing to the other with all the complex factors and things that like everyone's sort of dealing with at the various levels? Is there a world where the American people can expect a little bit more of a strategic approach to some of these questions that sort of works for them, right? So they don't wake up one day and get a letter that says, sorry, your premium's higher, or sorry, you got to change your coverage again, or what have you. So I'm just going to kind of like in 3 minutes, let everyone just answer that question or chime in. I mean, what does it take to get from shorter term to longer term thinking?
I kind of interpret that as like, when is Congress going to fix itself? That's so, you see the world with your own lens, right? So I don't know. I mean, I feel like I'm still, I don't want to say, I'm still kind of impacted by the 2017 experience, right? Of like, you had Republicans come in and they had the House and the Senate and the White House, and like, repeal and replace was the big thing, and like couldn't pull that off. And then you had this moment where you actually had this like bipartisan, like all of these working groups and the members were working together, and we had all these different breakfasts. And actually, I remember we had hearings, and Governor Hickenlooper came, and you had like, bipartisanship at the state level, and like we're like, oh my gosh, we're gonna legislate. And then it got too political and blew up. And so for me, like, I don't know what it's going to take. It's kind of almost a combination of like crisis plus divided government. Because I think when you have one party that's like solely in charge, there's so much pressure of like, oh, you have this moment and you have this agenda, and neither party will let their members walk away from like the whole of what they're to be able to, for somebody like Lamar Alexander to be able to do that bipartisan work, the repeal and replace had to die, which is why the sequencing we just talked about happened. But even then, it had to be there. It was that plus a crisis. And so I don't really know. I just am, shocked that we're still kind of at where we are in this conversation. Because I think even as somebody who worked for Senate Republicans, there are conversations that you could have around, okay, so maybe the subsidies stay in place, but let's talk about flexibility around plan design. Let's talk about, 1332 waivers. Like, there are things that you can talk about that could bring, more competition into the market, and let's have that dialogue. But if you can't even engage, I think that's what becomes really, really challenging. And it's been 10 plus years of not being able to engage. And so it's going to take a lot to be able to kind of unwind from that. Again, ray of sunshine right here, always.
Ray of sunshine. Well, this is clearly a to be continued conversation. I think there's still a lot of conversation to be had. There's a lot of action to watch for over the next couple of weeks. I know folks like Kevin and Scott have their hands full in terms of just operationalizing this stuff. Those of us at the sort of policy level and then political level have a lot to watch for. But I hope we can kind of conclude, and we are out of time, but just I think for all of us, kind of whether people are waking up and identifying as Republican or Democrat or whatever it is, that at some point, all of these complexities really do impact people's lives, and so that there's still a lot of work to be done to get to a better place there. But in the meantime, I want to thank Elizabeth Rowe, Katie Keith, Kevin Patterson, Scott Brockman, and of course, Sarah Collins for joining us today. Thank you for all of the deep thinking and analysis and work that you do. We're going to, next week, after 2.5 years of webinars, we're going to be, take the survey, please take the survey. We do take everyone's comments into account as we plan our future programming. Next week, we have our first in-person event in 2.5 years. The Alliance does, so we're going to be talking about mental health in America at our summit. We're super excited. We have bipartisan congressional leaders sending remarks by video. We have Secretary Becerra will be joining us for a fireside chat, and we have the real life perspectives of some really, really special people. So I hope that you can join us for that. For those who want to watch a recording of the webinar or check out the additional materials, check out allhealthpolicy.org. And I am 1 minute late, so I'm sending you back into your hopefully sunny and lovely afternoons. Thank you so much again for joining us today, and have a great weekend, everybody.